Hello, this is Ileana Pina, now from Detroit Medical Center and Wayne State University. I am here at the American College of Cardiology in beautiful New Orleans, where it has been raining and cold, but seeing a lot of friends and a lot of colleagues, a lot of excitement at this meeting. Very well done, very well prepared. So I wanted to talk to you about a topic that I have brought out before, and that is about the withdrawal of guideline-directed medical therapy. I have often told you on this blog that I really shun away from stopping the medications, even when the patients get better, which means even when the ejection fraction normalizes and the ventricle has shrunken down. We often get patients saying to us, "Don't you want to stop anything?" Or we'll get the primary care physicians asking us, "Can I stop any of the drugs, including the renin-angiotensin-aldosterone blocker, whether it's an ACE, an ARB, or the ARNI, or can I stop the spironolactone and the beta blocker, which are really the three foundations of drugs that we use?" Well, I think we're starting to get some view into this. Small study by Martin Cowie's group in the UK recently published, called the TREAD-HF, actually took 51 patients who had improved, who were doing well from HFrEF and had shrunken the ventricle, ejection fractions had gone up, and they divided them up into two groups. 26 of those patients they left on the same drugs. 25 patients, so 26 patients and 25 patients, they actually started withdrawing the drugs. And they looked at the patients again several months later. I believe it was close to 6 months later. And in the patients that had been withdrawn, a good number of them had regressed. And they defined the regression as a drop in 10% or more of ejection fraction, or they had a limit on changes in the ventricular function. So I think we're getting some data that you don't do that. Many of us that have been taking care of these patients for years know that when they stop the drugs, many of them revert right back, or they become non-adherent and they will revert right back. Another very interesting trial, not a trial, but a report from Get With The Guidelines that appeared in JACC, Heart Failure, just a few weeks ago, talking about initiation, continuation, and withdrawal of therapy. And again, this group looked at Get With The Guidelines, where you can actually see what the patients are going home on and if the drugs have been started in the hospital. And yes, the patients who were started in the hospital and kept on it seem to have better outcomes. But I find very intriguing the withdrawal group. And there are some curves in that paper that you can look at that will show you that the patients that are withdrawn from the drugs don't do so well and have a higher mortality and have a higher event rate. Why? Are those patients the ones that are really skidding, that we should be thinking about advanced therapies? Or are those the patients that the clinicians are afraid and they're not up-titrating the drugs, or they're taking them away because maybe the creatinine went up a bit? However, that creatinine going up a bit did not affect outcomes. So I think you really have to think twice before you pull back that therapy, because maybe the good benefits that you had will be gone. And it's a conversation that you must have with the patients to tell them that you are hesitant to stop the drugs. Make it easy for them. Make the drugs once a day if you have to, but just don't stop them. Thank you today for your time with me. This is Ileana Pina, signing off from New Orleans.